Welcome back, everyone. Today we'll be taking a deep dive into diabetes mellitus. Um, as nurses, I'm sure we've all encountered it in our practice in one way or another.
It really is a condition that touches so many aspects of healthcare.
Yeah, it really is. And we'll be going beyond just the basics. For example, did you know there's a type of diabetes that specifically pops up during pregnancy?
That's right, gestational diabetes. It's a fascinating and somewhat unique presentation of this condition.
Absolutely. We'll get into that later. But first, maybe a question for you. Have you ever heard about how insulin used to be extracted from animals?
Oh, absolutely. It's a bit of a historical quirk, but it really highlights how far we've come in diabetes treatment.
It really does. We'll touch on those stories, plus some newer advancements like inhaled insulin. But to start, let's set the stage. Our bodies need fuel, right? And our main source of energy is?
Glucose. It's what powers our cells and keeps everything running smoothly.
Exactly. But the level of glucose in our blood needs to be carefully balanced. And that's where the pancreas, this incredible organ, comes in.
The pancreas has a sort of dual role. It's involved in digestion, breaking down food, but it also has this vital endocrine function.
Endocrine, meaning it produces hormones.
Exactly. And the hormones we're focusing on here are insulin and glucagon. They're the dynamic duo that keep our blood glucose in check.
So it's a teamwork situation. How do they actually work together?
Okay, so picture this. You've just finished a delicious meal.
Oh, I can picture that.
Right. Now, naturally, your blood glucose levels are going to rise. And this rise is what triggers the beta cells in your pancreas to release insulin.
Okay, so the beta cells produce insulin.
That's right. Now, insulin acts like a key. It unlocks the doors to your cells, allowing glucose to enter.
Oh, I see. So the glucose can then be used for energy or stored away for later use.
Precisely. It's an efficient system designed to prevent that glucose from going to waste.
That makes sense. But what happens when our blood glucose levels drop too low? Like, say, between meals or if we've been exercising?
Well, in that case, a different set of cells in the pancreas, the alpha cells, jump into action.
Okay, and what do?
They release another hormone called glucagon. Glucagon's job is to signal the liver to release stored glucose back into the bloodstream. Think of it like tapping into our emergency reserves.
Ah, that's so interesting. So it's this constant back and forth, this balancing act between insulin and glucagon to maintain that perfect blood glucose level.
It's a truly remarkable system, but sometimes this intricate dance can be disrupted, and that's when we start talking about diabetes mellitus.
Diabetes, a condition we hear about all the time, but can you give us a clear, concise definition?
Certainly. Diabetes mellitus is essentially a condition where the body struggles to effectively use glucose for energy, leading to elevated blood sugar levels.
Elevated blood sugar, meaning hyperglycemia, right?
That's correct. And there are specific ways we diagnose diabetes. One is through the fasting plasma glucose test.
Fasting, meaning the patient hasn't eaten for a certain period of time.
Exactly, typically for at least 8 hours. If their fasting blood glucose is 126 milligrams per deciliter or higher on multiple tests, that's a strong indicator of diabetes.
And I believe another important test is the hemoglobin A1C test.
Absolutely. The A1C test gives us a broader picture. It shows the average blood glucose levels over the past 2 to 3 months, not just a snapshot in time.
So it's like getting a long-term view of blood sugar control.
Precisely. And if the A1C level is 6.5% or greater, that also points towards a diagnosis of diabetes.
Now, I know there are different types of diabetes. Let's unpack them, starting with type 1.
Type 1 diabetes is an autoimmune disease. It's where the body's own immune system mistakenly attacks the beta cells in the pancreas, those cells responsible for producing insulin.
So in type 1, there's a complete lack of insulin production.
Essentially, yes. The beta cells are destroyed, and the body can no longer produce the insulin it needs.
That's a serious problem, given the crucial role insulin plays in regulating blood glucose.
It is. And it means that individuals with type 1 diabetes require lifelong insulin therapy to manage their condition.
So they're essentially taking on the role of their pancreas, providing the insulin externally.
That's one way to think about it. It's a demanding but essential aspect of managing type 1 diabetes.
And what about type 2 diabetes? It seems to be much more common these days.
Type 2 diabetes is indeed far more prevalent, and it's a bit more complex. There's a combination of insulin resistance, meaning the body's cells aren't responding to insulin as effectively, and a decrease in insulin production by the pancreas.
Well, it's a double whammy.
In a way, yes. The body is struggling to use the insulin it does have, and the pancreas isn't producing enough to keep up.
What are the main factors that contribute to this?
Well, there are a few. Genetics certainly play a role, as does family history. Ethnicity and age also contribute to the risk. But one of the most significant factors is obesity.
That makes sense, given the link between obesity and metabolic health.
Exactly. Excess weight, particularly abdominal fat, can really interfere with the body's ability to use insulin effectively.
So, lifestyle choices play a critical role in both the development and management of type 2 diabetes.
Absolutely. And that's something we'll delve deeper into later on.
Now, you mentioned earlier a type of diabetes that emerges during pregnancy. Gestational diabetes, is that right?
Yes, that's right. It's a form of diabetes that develops during pregnancy, usually in the later stages. It's thought to be caused by the hormonal changes that occur.
So it's almost like a temporary form of diabetes brought on by the unique demands of pregnancy.
In a way, yes. And thankfully, it often resolves after delivery. However, it's important to note that it does increase the risk of developing type 2 diabetes later in life.
So it's something to keep an eye on even after the pregnancy.
Absolutely. It's crucial to monitor for any signs or symptoms and take steps to minimize the risk.
Well, we've laid a great foundation, I think, understanding diabetes. But before we move on, let's take a moment to revisit some key terms. What do we mean by diabetes mellitus?
Diabetes mellitus, often simply called diabetes, is all about hyperglycemia, those elevated blood sugar levels. It's caused by issues with insulin, either not enough being produced or the body not responding to it properly.
And glucose, that's the fuel source, right?
Exactly. Glucose is a simple sugar, and it's the main source of energy for our cells. It comes from the carbohydrates in our food. In diabetes, the problem is that the body can't use that glucose effectively.
And we talked about the A1C test. Can you remind us what that measures and why it's important?
The A1C test looks at the average blood glucose levels over a longer period, 2 to 3 months. It's a valuable tool for assessing long-term blood sugar control, not just a single point in time.
So it's like seeing the big picture.
Exactly. And if those A1C levels are consistently high, it can lead to serious complications.
Complications like what?
High blood sugar, over time, can damage blood vessels and nerves. This can lead to problems like heart disease, stroke, kidney disease, even vision loss.
That's a sobering reminder of why managing diabetes is so crucial.
It really is. We need to do everything we can to keep those blood sugar levels in a healthy range.
Now let's talk about insulin resistance. What exactly does that mean?
Think of insulin as a key that unlocks the doors to your cells, allowing glucose to enter and be used for energy. Insulin resistance is like those locks getting rusty. The key doesn't work as well, and the glucose has trouble getting into the cells.
So the glucose builds up in the bloodstream instead.
Exactly. And that's when we see those elevated blood sugar levels.
Now, on the flip side, we have hypoglycemia or low blood sugar. Why is that a concern, especially for people with diabetes?
Our brains rely on glucose. It's their primary fuel source. So when blood sugar levels drop too low, it can really impair brain function.
And that can manifest in a variety of ways, right?
Absolutely. We might see things like shakiness, sweating, a rapid heartbeat, even confusion and dizziness. In severe cases, it can lead to seizures or loss of consciousness.
It sounds like hypoglycemia is something that needs to be addressed quickly.
Absolutely. It's crucial to recognize the signs and symptoms and take action to raise blood sugar levels promptly.
Okay, one last term for now. Diabetic ketoacidosis, or DKA. What is that, and why is it considered a serious complication?
DKA happens when the body doesn't have enough insulin to use glucose for energy, so it starts breaking down fat for fuel instead.
And that process produces ketones, right?
Exactly, and ketones are acidic. When they build up in the blood, they make the blood too acidic, which can be life-threatening.
So it's a metabolic emergency.
Absolutely. DKA is most common in type 1 diabetes, but it can occur in type 2 as well, especially during times of illness or stress.
What are some of the warning signs of DKA?
Things like excessive thirst, frequent urination, nausea, vomiting, abdominal pain, also weakness, fatigue, shortness of breath, and even a fruity smell on the breath.
Important signs to be aware of. Well, we've covered an incredible amount of ground already.
We've really delved into the complexities of diabetes, from its various types to the key terms and concepts that are crucial for understanding this condition.
It's been a fantastic overview. And in our next segment, we'll put this knowledge into practice, tackling some review questions that will test our understanding and spark further discussion.
I'm looking forward to diving into those questions and exploring the practical applications of what we've learned. Let's dive into some review questions. These aren't just about memorizing facts. They're about making those connections that are so crucial in nursing practice.
Exactly. It's about applying that knowledge to real-world patient care.
Ready for the first one?
Bring it on! I'm always up for a good challenge.
Okay, here we go. Which is the most appropriate timing regarding the nurse's administration of a rapid-acting insulin to a hospitalized patient? So we're talking about rapid-acting insulin here. Think Humalog, Novolog, those types.
Right, and timing is everything with insulin.
Absolutely. So let's look at the options.
Okay, the options are: give it 15 minutes before the patient begins a meal. B, give it half an hour before a meal. C, give it 1 hour after a meal. D, the timing of the insulin injection does not matter with insulin lispro.
Option D is definitely out. Timing is crucial, especially with rapid-acting insulins.
Right, we want to make sure the insulin's action matches the food intake.
Exactly. So thinking about rapid-acting insulin, option A, giving it 15 minutes before the meal, makes the most sense.
Yeah, because it kicks in quickly.
Precisely. We want to avoid giving it too early, like option B, half an hour before, because that could lead to hypoglycemia.
And option C, giving it an hour after the meal, would be too late.
Exactly. The peak action of rapid-acting insulin is around an hour. We'd miss that critical window for controlling blood sugar after the meal.
So A, it is 15 minutes before the meal. On to the next question.
Let's do it. Question number 2 is about patient teaching for type 2 diabetes. The question is, which statement is appropriate for the nurse to include in patient teaching regarding type 2 diabetes?
Patient education is so vital in diabetes care.
It really is. It empowers patients to take an active role in managing their condition.
All right, here are the options. A, insulin injections are never used with type 2 diabetes. B, you don't need to measure your blood glucose levels because you are not taking insulin injections. C, a person with type 2 diabetes still has some functioning beta cells in his or her pancreas. D, patients with type 2 diabetes usually have better control over their diabetes than those with type 1 diabetes.
Let's start by debunking a few myths. Option A, insulin injections are never used with type 2 diabetes. That's simply not true.
Right. Many people with type 2 eventually require insulin.
And option B, not needing to measure blood glucose if you're not on insulin, that's also incorrect. Monitoring blood sugar is essential for everyone with diabetes.
It helps us track how well the treatment plan is working.
Exactly. Now, option D, saying that type 2 is always better controlled than type 1, that's a generalization we want to avoid.
Blood sugar control depends on so many factors, right? Individual effort, lifestyle, medication adherence.
Absolutely. It's not a competition. Everyone's journey with diabetes is unique.
So that leaves us with option C. A person with type 2 diabetes still has some functioning beta cells in his or her pancreas.
That's the key difference between type 1 and type 2. In type 1, those beta cells are destroyed. But in type 2, they're still there, just not working as efficiently.
It's like their insulin production line is slowed down, or the cells aren't responding to the insulin as well.
Exactly. And that's important for patients to understand. It reinforces that their pancreas is still in the game, even if it needs a little help.
On to question number 3.
Let's tackle it. This one is all about evaluating the response to oral diabetes medications. The question is, the nurse monitoring a patient for a therapeutic response to oral diabetes drugs will look for which of these?
So we're looking for signs that the medication is doing its job.
Precisely. Is it helping the patient achieve better blood sugar control?
Okay, here are the options. A, fewer episodes of diabetic ketoacidosis. B, weight loss of 5 pounds. C, hemoglobin A1C levels of less than 7%. D, glucose levels of 150 milligrams per deciliter.
Let's break it down. Option A, fewer episodes of DKA. That's more relevant to type 1 diabetes, where there's a complete lack of insulin. Oral medications are usually for type 2.
So while preventing DKA is always a goal, it's not the primary indicator of a therapeutic response to these medications.
Right. What about option B, weight loss of 5 pounds? While weight loss can be beneficial, it's not the sole focus of all oral diabetes medications.
Some medications might primarily target blood sugar levels without significant weight loss.
Exactly. And option D, a glucose level of 150, while lower than the diagnostic threshold, is still considered elevated. We aim for tighter control.
So that leaves us with option C, hemoglobin A1C levels of less than 7%.
That's our winner. Remember, A1C reflects long-term blood sugar control. Achieving an A1C below 7% generally indicates the medication is working effectively.
It's not just about a single glucose reading, it's about the overall trend.
Exactly. We're looking for sustained improvement in blood sugar management. All right, moving on to question number 4.
This one involves metformin and medical imaging. It says, a patient with type 2 diabetes is scheduled for magnetic resonance imaging, MRI, with contrast dye. The nurse reviews the orders and notices that the patient is receiving metformin. Which action by the nurse is appropriate?
Ah, this is a classic example of a potential drug interaction we need to be aware of.
Right. The contrast dye used in some imaging procedures can interact with certain medications.
Exactly. And in the case of metformin, there's a risk of lactic acidosis, a serious condition that can affect the kidneys.
So we need to proceed cautiously.
Absolutely. Let's look at the options. A, proceed with the MRI as scheduled. B, notify the radiology department that the patient is receiving metformin. C, expect to hold the metformin the day of the test and for 48 hours after the test is performed. D, call the prescriber regarding holding the metformin for 2 days before the MRI is performed.
Option A, proceeding as scheduled, is definitely not the right approach. We can't ignore the potential interaction.
Agreed. And option B, notifying radiology, while important for communication, doesn't address the need to adjust the medication. That decision lies with the prescriber.
What about option D, holding metformin for 2 days before the MRI? Isn't that being extra cautious?
While consulting the prescriber is always good practice, holding metformin for that long might be unnecessary and disrupt blood sugar control.
So option C seems to be the most appropriate action. Expect to hold the metformin the day of the test and for 48 hours after the test is performed.
Exactly. That aligns with the standard protocol for managing metformin in these situations. It minimizes the risk of lactic acidosis while ensuring blood sugar levels remain as stable as possible.
It's all about finding that balance between safety and effective diabetes management.
Precisely. On to question 5.
Let's keep this momentum going.
All right, this one is about repaglinide, a medication in the glycinide class. It says, a patient with type 2 diabetes has a new prescription for repaglinide. After 1 week, she calls the office to ask what to do because she keeps missing meals. I work right through lunch sometimes, and I'm not sure whether I need to take it. What do I need to do? What is the nurse's best response?
Oh, this is a common scenario.
Yeah.
Life gets in the way, and medication schedules can be tough to stick to.
Absolutely, and it's crucial to provide clear instructions on what to do in these situations.
Let's see what options we have here. A, you need to try not to skip meals, but if that happens, you will need to skip that dose of Prandon. B, we will probably need to change your prescription to insulin injections because you can't eat meals on a regular basis. C, go ahead and take the pill when you first remember that you missed it. D, take both pills with the next meal and try to eat a little extra to make up for what you missed at lunchtime.
Option B, switching to insulin just because of occasional missed meals, that's jumping the gun a bit.
Right, insulin is a big step, and it might not be necessary in this case.
And option C, taking the pill when she remembers, that's risky with repaglinide. It's a short-acting medication taken before meals. Taking it without food could lead to hypoglycemia.
So we definitely want to avoid that. And doubling the dose, as in option D, is never a safe approach without consulting the prescriber.
Right. That could lead to a dangerous drop in blood sugar. So the best response here is option A. You need to try not to skip meals, but if that happens, you will need to skip that dose of Prandon.
That's the safest and most practical advice.
It highlights the importance of coordinating medication with food intake.
And it also emphasizes the importance of open communication. If a patient's routine changes, they should feel comfortable reaching out to their healthcare provider for guidance.
Absolutely. It's a partnership. All right, question number 6. This one deals with a low blood glucose reading, it says. When checking a patient's fingerstick blood glucose level, the nurse obtains a reading of 42 milligrams per deciliter. The patient is awake, but states he feels a bit cloudy-headed. After double-checking the patient's glucose level and getting the same reading, which action by the nurse is most appropriate?
Okay, a blood sugar of 42 is definitely concerning. That's hypoglycemia, and it needs to be addressed quickly.
Absolutely. We need to think fast and act decisively.
Let's see what our options are. A, administer 2 packets of table sugar. B, administer oral glucose in the form of a semi-solid gel. C, administer 50% dextrose IV push. D, administer the morning dose of Lispro insulin.
Option D, administering insulin, is a big no-no. Insulin would lower the blood sugar even further, making the situation worse.
Right. Insulin is never the answer for hypoglycemia.
Now, option A, table sugar, while it can raise blood sugar, it's not the fastest option.
We need something that will act quickly.
Option C, IV dextrose, is a rapid and effective way to raise blood sugar, but it's typically reserved for severe cases where the patient is unconscious or can't take anything by mouth.
Right. In this case, the patient is awake and can swallow.
So the best choice is option B, oral glucose gel. It's a quick and convenient way to raise blood sugar and generally well tolerated.
It's readily available and easy to administer.
Exactly. And after giving the glucose gel, we would continue to monitor the patient's blood sugar closely to make sure it rises to a safe level.
All right, question number 7. It asks, a patient is taking metformin for new-onset type 2 diabetes mellitus. When reviewing potential adverse effects, the nurse will include information about.
Metformin is a first-line medication for type 2 diabetes, but it's important to be aware of potential side effects.
Right. Knowledge is power when it comes to managing medications.
Absolutely. So the options are A, abdominal bloating, B, nausea, C, diarrhea, D, headache, E, weight gain, F, metallic taste.
Now, metformin is known to cause some gastrointestinal side effects, especially early on in treatment.
That's right. So the most common side effects we'd want to inform the patient about are A, abdominal bloating, B, nausea, C, diarrhea, and F, metallic taste.
Not the most pleasant side effects, but important to be prepared for.
Absolutely. We want to educate patients so they know what to expect and don't get discouraged.
And hopefully those side effects will subside over time,
Often they do, and there are things we can do to help manage them.
like taking the medication with food.
Exactly, and staying well hydrated. But the key is to communicate. If the side effects are bothersome, the patient should let their healthcare provider know.
All right, on to our final question in this segment, question 8.
This one is about inhaled insulin. The question asks, a patient who has a new diagnosis of type 2 diabetes asks the nurse about a new insulin that can be inhaled. Is there a reason I can't take that drug? Which conditions, if present in the patient, would be a concern?
Inhaled insulin, that's a newer option that can be appealing to some patients.
It is. But as with any medication, there are considerations.
Let's look at the potential concerns listed. A, atrial fibrillation. B, history of smoking. C, chronic lung disease. D, hypothyroidism. E, rheumatoid arthritis.
Now, inhaled insulin is delivered directly into the lungs. So the biggest concerns here would be B, a history of smoking, and C, chronic lung disease.
Conditions that could affect lung function.
Exactly. Smoking and lung diseases like asthma or COPD could make inhaled insulin less effective and potentially risky.
So a thorough respiratory assessment is crucial before considering this option.
Absolutely. We need to make sure it's safe and appropriate for the individual patient.
All right, welcome back. In the last 2 segments, we've really dug deep into diabetes. Now we're going to shift gears and apply all that knowledge to a case study.
I love case studies. They bring those textbook concepts to life and show how we actually use this information in clinical practice.
Exactly. So let's meet our patient, BG. He's a 58-year-old man diagnosed with type 2 diabetes 10 years ago. Interestingly, despite having type 2, he's been requiring insulin for the past 2 years.
It happens sometimes. As type 2 diabetes progresses, the pancreas may not be able to keep up with the body's insulin demands.
That makes sense. Now, BG is recovering from a laparoscopic cholecystectomy, a minimally invasive procedure to remove the gallbladder.
Right. And thankfully, his recovery has been smooth, no complications.
That's good to hear. But there's always something, right? What's the issue we're facing with BG?
His blood glucose levels have been a bit all over the place in the past 24 hours, fluctuating quite a bit.
Ah, that's not uncommon after surgery. Stress, medications, changes in routine, it can all affect blood sugar.
Exactly. So to address these situations, his physician has decided to switch his insulin regimen from regular insulin to insulin Lispro. Humalog, that's the brand name.
Okay, a change in insulin type. Can you quickly remind us about the key differences between regular insulin and insulin Lispro?
Sure. Regular insulin is a short-acting insulin. It takes about 30 to 60 minutes to start working, peaks in 2 to 3 hours, and lasts for 5 to 8 hours.
So it's not immediate.
Right. Insulin Lispro, on the other hand, is rapid-acting. It starts working much faster, within 15 minutes, peaks in about an hour, and lasts for a shorter duration, around 3 to 5 hours.
So it's quicker, but doesn't hang around as long.
Precisely. Now, before we dive deeper into BG's case, there's one more piece of information. His hemoglobin A1C level was 9% before surgery.
Okay, A1C. That gives us a sense of his long-term blood sugar control.
Exactly. And an A1C of 9% is significantly higher than the target of less than 7%. It tells us his blood sugar control hasn't been optimal leading up to the surgery.
That's a red flag. Elevated blood sugar can increase the risk of complications during and after surgery.
Absolutely. So close monitoring is essential. Now, the second question in this case study focuses on BG's understanding of his new insulin regimen. He mentions his previous routine with regular insulin, saying, I took my regular insulin shots about 30 minutes before my meals. Hopefully I can keep that same routine. How should the nurse respond to this statement?
That's where patient education is crucial. We need to make sure he understands that the timing for insulin lispro is different.
Exactly. The nurse should explain to BG that because insulin lispro works much faster, injecting it 30 minutes before a meal could cause his blood sugar to drop too low before he even starts eating.
So hypoglycemia is a real concern. What would be the correct timing for BG to take his insulin lispro injections?
He should aim to inject it within 15 minutes of starting a meal. He can even do it during the meal if that's easier. This timing ensures that the insulin's peak action coincides with the rise in blood sugar from the food.
It's all about matching the insulin action to the food intake.
Precisely. Now, the final question in BG's case presents a scenario that highlights the importance of being prepared for unexpected situations. After being discharged from the hospital, BG wakes up one morning feeling nauseated. He administers his insulin lispro injection as instructed, but then, after eating breakfast, he vomits and can't keep any food down. What should he do at this time?
Oh, that's tricky. He's taken his insulin, but his body might not be absorbing the glucose from his food because of the vomiting.
Exactly. That puts him at risk for hypoglycemia. The nurse should advise BG to monitor his blood glucose levels very closely and consider consuming a quick source of glucose, like juice or glucose tablets, to counteract the insulin that's already in his system.
So basically, he needs to replenish his glucose stores, even though he can't keep food down.
Right. And it's also crucial for him to contact his healthcare provider as soon as possible. They can assess the situation and provide further guidance on managing his insulin regimen, especially in light of this illness.
This case study really brings home the importance of everything we've talked about today.
It shows how the principles of diabetes management, insulin types, and potential complications all play a role in real-life patient care.
And it highlights the need for ongoing patient education, clear communication, and a collaborative approach to diabetes management.
Couldn't have said it better myself.
Well, listeners, we've reached the end of our deep dive into diabetes mellitus. We've covered a lot of ground, but remember, this is just the beginning of your journey.
Keep learning, keep asking questions, and most importantly, keep advocating for your patients. Their health and well-being depend on it.
That's right. Until next time, stay curious and stay informed.